So to start with, we do see a lot of patients with hypothyroidism in the clinic, and many of them, or most of them, are actually well controlled and followed through their primary care physicians or through their internal medicine physicians. However, sometimes they are referred back to us for uncontrolled hypothyroidism, or sometimes some of the patients that we follow, we notice that their thyroid hormone levels or their symptoms suggest uncontrolled hypothyroidism. I have no disclosures. So the objectives for tonight are to define the types of hypothyroidism, to review treatment goals and pharmacotherapy, and also to discuss the most frequently encountered pitfalls in managing hypothyroidism. So to define hypothyroidism, so you actually have a few categories of patients that you see and you treat in the clinic. Some of them have the most classical presentation, right, is the overt primary hypothyroidism, where the TSH is elevated and then the T4 is decreased. In more advanced cases, even the T3 can be decreased. Then you have the more mild situations of subclinical hypothyroidism, where the TSH is high, but the free T4 is still normal, and T3 in most cases is and should be normal. And then you have the less common situation of central hypothyroidism, where the patients have a low free T4 with low inappropriately normal TSH, and that is because the pituitary does not mount the appropriate TSH response to the low T4 production. The treatment goals for these patients are to improve their symptoms, to normalize serum TSH, if they have a goiter, to reduce that size, and also to avoid overtreatment or otherwise called iatrogenic thyrotoxicosis. And I wanted to make a mention here. The first point is the first goal that I listed there is to improve the symptoms. It's not necessarily to resolve the symptoms completely. And that's because many of these patients, despite all the treatment that we offer and all the adjustments that we made, still complain that they don't feel back to their baseline from before they were diagnosed with hypothyroidism. In terms of the standard treatment options, that is levothyroxine, or the T4. And that's because the body has the capacity to convert T4 and T3. So really, the vast majority of patients with hypothyroidism should do well and only require treatment with T4. At this point, there are a number of options for levothyroxine. So it comes in a tablet form, right, as generic levothyroxine, or a number of brand. It also comes in a gel cap form, and the most common one there is the Tyrosine. And then it also comes in a liquid form, and there are a number of brands on the market. Tyrosine solution is probably the most common that at least we use. And that would be indicated in patients who either have some absorption issues or have difficulty swallowing tablets. And like I mentioned, this come both as generic and various brands. So when you have a newly diagnosed patient with hypothyroidism, where do you start in terms of the dose? Usually, for somebody who's healthy, doesn't have comorbidities like coronary artery disease, and they're relatively young, you can start with full replacement. And a good place to start is by calculated the dose by according to their weight. So it's usually 1.6 micrograms per kilogram. However, because of the variability in absorption, this can range greatly, anywhere between 50 to 200 micrograms, and sometimes even more than that. Like I mentioned, if the patients are older, typically over 60, or if they have coronary or cardiac issues, it's safer to start with a lower dose in the range of 20 to 50 micrograms, and then to titrate up until you reach basically a normal TSH. Or the TSH goal, like we're going to talk about. So the proper way, where we often get into trouble, the proper way of taking the thyroid hormone is on an empty stomach in the morning. And, it's surprising to see how many patients sometimes come back after being on levothyroxine for years and years, and they say they don't know that. They didn't know they were supposed to take it this way. But really because of the sensitivity of the levothyroxine absorption to what else is in the stomach, the pH in the stomach, this is the proper way to take it. So it should be taken with just water, and like I mentioned, at least 30 to 60 minutes apart from food and other medication. Now, some patients, and there are studies on populations, depending on their lifestyle, it's more feasible to take it 2 hours after, or to take it after dinner or at bedtime especially. So for those particular patients, the recommendation is to take it at least 2 hours after dinner. So it really, for most of the United States, this is not really feasible because usually people eat late and then they go to bed, so this would not really work in most patients. People should notice the improvement in their symptoms in about 2 weeks because that's when the T4 would reach a steady state. However, the TSH typically trails behind, so it usually takes 4 to 6 weeks at the minimum for the TSH to reach its steady state, and that's when it should be measured. Now, there are less common pharmacotherapy options, less common or less desired if you want, and those are the T3, T4 combinations. And that can be achieved by either adding glycyrrhizine, which is the T3, right, to the levothyroxine, or using desiccated thyroid, such as the Armour's desiccated pig thyroid, Armour thyroid, or there's a number of compounded formulations done by compound pharmacies that include T4, T3 in various ratios. So having said that, so after this introduction, I just wanted to illustrate our challenges by presenting a few cases. And the first one is of a 30-year-old female with a history of Graves' disease. She was diagnosed approximately 3 years prior. She decided for treatment with radioactive iodine, and she developed post-RAI hypothyroidism. So she presents to the clinic for a scheduled follow-up. She has been on levothyroxine generic, which she was taking correctly, 88 micrograms. And today, in the clinic, she was complaining of occasional palpitations, but nothing else in terms of complaints, doing otherwise okay. So not a lot in terms of her medical or surgical history. She only had Graves' disease. Her medication list included levothyroxine at 88 micrograms. Then she was also on oral contraceptives. And then she was taking a supplement, the ashwagandha root extract. Her physical exam was really unremarkable. Her weight was stable. When we got her laboratory testing back, her TSH was suppressed at 0.1, while previously was mid-normal at 2.7. Her free T4 was also mildly above the range at 2.0, upper normal is 1.9. 1.7. So the question came, why this recent decrease in her TSH? Was there any change in her lifestyle? Did she change anything in her diet? Was her weight different? But she said it wasn't. Of note, a 10% change in the body mass, especially the lean body mass, either up or down, may lead to a requirement to increase the levothyroxine or to change the levothyroxine dose up or down, depending on whether there was weight gain versus weight loss. Then, were there any changes in her medications? And last but not least, was that a true change? Sometimes you can have recent illness that causes thyroid syndrome with transient abnormalities in the thyroid hormone levels, or sometimes we see lab errors or interferences like biotin, for example, which biotin can artificially lower the TSH measurement. So this is an overview of her laboratory testing. Ever since she was diagnosed with hyperthyroidism and treated with radioactive iodine, which is far left, and then all the way to current, so to the 0.1 milliu per liter, which was at the time of that appointment. And then on the bottom, you can see her doses. So initially after the treatment, she was prescribed a higher dose, which had to be titrated because her TSH was suppressed, and then it stabilized. So what happened there was actually she had discontinued her oral contraceptive a few months earlier. And what we know is that the estrogens, whether it's oral contraceptives or hormone replacement therapy in postmenopausal women, would lead to an increase in the thyroid binding globulin in the blood, which binds more of the T4, right? So in that case, you have a less of a free fraction of T4 with a resultant increase in the TSH. The opposite situation we also see in women going through menopause, or like this, when her oral contraceptives were stopped or where hormone replacement therapy stopped. That will result in the increase in the free T4 fraction with a resultant decrease in TSH. So what we needed to do in this case was to adjust her thyroid hormone dose. We decreased it to 75 micrograms, and then her TSH normalized. So I want to, because she was on this supplement, on this ashwagandha root extract, I just wanted to mention a couple of things about the supplements. So this particular herb, also called Vitania somnifera, has been used for thousands and thousands of years. I think it originates in India. And it's part of the over-the-counter supplements used for chronic stress and anxiety. It's thought to have anti-inflammatory properties, but it's also associated in case reports with an increased T4 level, but not T3 levels. And there were a couple of case reports in the literature that actually reported that it caused thyrotoxicosis, over-thyrotoxicosis, which resolved after the patient stopped the supplement. However, those case reports did not provide information on how much those patients were taking. So really, this particular patient continued to take her supplement at the previous, fairly low dose, and her levels normalized. The second case is of a 69-year-old gentleman who I've been following for quite some time in the clinic for a history of papillary thyroid cancer. That was treated with total thyroidectomy, and he had no evidence of recurrent disease. So obviously he had post-surgical hypothyroidism. He had been on a very stable dose of 125 micrograms of levothyroxine daily. So he comes for his annual surveillance in our survivorship clinic, and he really has no complaints. In terms of his medical and surgical history, like I mentioned, he had the papillary thyroid cancer. He also had diabetes that was well controlled, and he had hypertension, also well controlled. The medication list included levothyroxine, as I mentioned. For diabetes, he was taking glargine insulin at 10 units daily, and then a correction scale with aspart insulin for meals, required anywhere between 2 and 8 units. Then for the hypertension, he was taking low doses lisinopril and metoprolol, and he also was taking an over-the-counter multivitamin. His physical exam was unremarkable. Other than his thyroidectomy scar, there was really nothing striking. But then his laboratory testing come back, and his TSH was mildly above the range at 6.0 with a free T4 at the lower end at 0.8. Thyroglobulin was undetectable, the antibodies were negative, and the ultrasound was also didn't show anything suspicious. So while we were very happy that despite the high TSH, he didn't have any biochemical or anatomical evidence of papillary thyroid cancer recurrence, we still were faced with this elevated TSH. So the same questions applied to him as well. And at this point, we really weren't able to get any explanation for this abnormality. So he denied any changes in his lifestyle, in his diet. His weight was stable. He wasn't taking any other additional medications. And because we weren't sure if this was true, we actually repeated it so we were thinking, okay, maybe this is a lab error. So actually what was happening with this gentleman was, and his wife pointed that out, he had changed his multivitamin the preparation, and this one contained extra calcium, which interferes with the thyroid hormone absorption. So because of that, I wanted to list some of other medications that interfere with the thyroid hormone absorption, and they're here on the slide. So it's iron supplements and calcium supplements are probably the most common situations that we see in the clinic. And what we tell the patients is to space that out at least 4 hours from the thyroid hormone. So take them with lunch and with dinner if they take the levothyroxine in the morning. And then there are other culprits like aluminum hydroxide, sertraline, or loxaphen, which was more commonly used for osteoporosis in the past, but not that much now, and omeprazole. It's not just the drugs that interfere with absorption that can cause problems. There are also medications that increase the catabolism of T4, and that would include rifampin, carbamazepine, phenytoin, phenobarbital. So we asked the patients about seizure disorders and then some of the tyrosine kinase inhibitors like imatinib. And not just medications, non-fasting state, like I mentioned, is a common problem, and then medical conditions that either interfere with the metabolism, like malabsorption processes, or with the increased excretion, like the nephrotic syndrome. So this is a paper that was published several years ago where they looked at the impact of the non-fasting state on the TSH levels. They had 65 patients that were subjected to 8-week regimens of fasting in the morning, taking the levothyroxine, or taking the levothyroxine with breakfast. And then the third regimen was taking the medication at bedtime. And then it was a 3-period crossover. So at every 8 weeks, they were changing this their regimen. So really, as a summary, as a primary outcome, the plasma TSH concentration was measured in all these situations. And as you can see here, let me see if I can, is this the pointer? Okay, so really the most consistent TSH values at goal were the ones when the levothyroxine was taken first thing in the morning. So this is the third case and the last one for this one. So this was a 71-year-old female that I actually very recently saw in the clinic. She had a long-standing history of hypothyroidism for a benign goiter, for which she had a total thyroidectomy. And important to mention that she never felt the same after the surgery, despite trying various thyroid hormone replacement strategies. So she was presenting for a second opinion regarding her optimization of thyroid hormone replacement. And usually when we see that, that means that the patient was really not happy with what she was told before that she should be doing. So at this time, she's been taking a combination of levothyroxine and liothyronine, which is T3. In terms of her medical history, she had the post-surgical hypothyroidism, as I mentioned. She also had a history of breast cancer. She had bilateral mastectomy, followed by adjuvant chemotherapy. It was in remission, but she was on chronic treatment with aromatase inhibitor. She also had osteopenia, according with her last bone mineral density. Her medication list, as you see there, she was on brand name Synthroid, and she was alternating or using a combination of 112 microgram strength 5 days a week, and then 125 2 days a week. Then her liothyronine had been recently decreased from 25 micrograms daily to 5 micrograms daily. She was also taking the aromatase inhibitor and the calcium plus D supplement. Her physical exam, again, was unremarkable from an endocrine standpoint. She only had the thyroidectomy scar, which was well healed, but no other pertinent positives. Her TSH was suppressed, 0.04, with a free T4 at 1.5. And I'm just going to take this opportunity to mention that when patients take combinations of T4 and T3, the free T4 and the T3 measurements are really not that informative because the ratios are very rarely similar to normal. And this is her history, basically. So I was able to get back in her chart as far back as 2016. I have to make the observation that some of these values, the in-between ones, have actually not been measured in our clinic. They were in various other places. And again, I was able to, I tried to put together as much of the information regarding to her history as possible. During the interview, she was a little bit, how do I say, evasive in giving me the detail to with respect to her current regimen. She said that, well, I ran out of the 112, so I started to take 125, which I had left over. Couldn't tell me exactly for how long she was taking that. So anyway, that was the situation. So it's also important to mention that in 2016, which was the only other presentation that I saw in our clinic in the past, so except for the last year, that actually was an emergency department visit for lightheadedness and palpitations, which was attributed to over-replacement with thyroid hormone. And then you can see the subsequent numbers. So she is over-replaced with thyroid hormone. That's it. It's not a mystery there. And this is a situation that should be avoided. And that sometimes that can be difficult to achieve in patients who think that their often non-specific symptoms are related to her thyroid or the amount of thyroid hormone that they're taking. So really, if despite a normal TSH, their symptoms persist, if their TSH is in the upper half of normal, you can try to adjust and basically fine-tune to a lower half of the normal range target. But there were very few situations where that actually truly made a consistent positive change in their symptoms. If the TSH is already in the middle or in the mid or lower half of the normal range, that's even more challenging because it's often that their symptoms are related to other causes and not really the replacement with thyroid hormone. But that's a situation where you can try to add T3 in selected cases. And usually when I do that, I kind of negotiate with the patient that it's on a trial basis only. If by 3 to 6 months they don't feel any difference, that should be discontinued because it means that it does not make a difference for them. And I'm going to take the opportunity to also mention another patient that I had who was very stable, on a very stable dose of levothyroxine, also a thyroid cancer patient, very stable dose, target TSH, no symptoms until the last appointment when she was complaining of feeling tired. And she was trying to ask for a thyroid hormone dose change because of this new symptom. And then but this was a new symptom. So when we went back and reviewed with the patient her medication list, it turned out that she was taking an allergy medication consistently daily for the last several months, where in the past was just sporadic. It was the claritine, loratadine that she was taking. And that's known to cause fatigue, and she also endorsed dry mouth with that as well, which was really not a symptom that she brought up to me initially, but it really turned out that was a medication side effect. So the reason for avoiding over-replacement with thyroid hormone really are to try to reduce the risk of cardiovascular complications, atrial fibrillation, and other cardiac arrhythmias. This was a population study in 2007, people who were followed over a 10-year period, and that included patients with basically subclinical hyperthyroidism, both iatrogenic or and for endogenous causes. And you can see in that graph basically that patients with a low T4 and TSH had a much higher incidence of cardiovascular or basically an atrial fibrillation event. The second risk is of bone loss. So again, patients who are over-replaced with thyroid hormone over time are at a higher risk of losing bone. This patient of mine that I just mentioned as case number 3 already had osteopenia. She also was on an aromatase inhibitor, so she had additional risk factors for that. So really, patients with a low TSH less than 0.3 in this particular population study also had a higher risk of hip fractures. And then in the patients with persistently low TSH, the risk was increased for both hip fractures and other osteoporotic fractures. The under-replacement with thyroid hormone can also be a problem. So there are 2 large retrospective studies that show that a TSH over 20 persistent was associated with increased cardiovascular-related mortality. Then a second study demonstrated that a TSH over 5.5 milliu per liter increased the risk of stroke. However, I have to make the observation there that in the elderly, actually a mildly increased TSH is considered to be normal. So there is a tendency for the TSH to increase as we age, especially in the 80th and 90th decade. And for patients with a normal free T4 and the TSH above the range but below 10 and asymptomatic, that wouldn't necessarily mean that there is a thyroid pathology there, and they don't necessarily need to be considered for treatment. So my take-home points for today really are that the goal of therapy is to improve the symptoms, to normalize the TSH, and to reduce the size of goiter if present, along with avoiding over-replacement. To emphasize that the levothyroxine alone should be the standard therapy, and only in extreme cases the T3 could be considered. As I mentioned, the initial dosing can be calculated per kilogram, but then it has to be adjusted based on the TSH, and patients with comorbidities should be started at lower doses. And then if the persistent symptoms, if there are persistent symptoms with monotherapy, then either further adjustment of the TSH or adding a T3 could be considered, but it is important to look for other causes. With this, I'm